Hi, everyone. So I will kick us off before I hand things over to our presenter today. Thank you so much for joining us on during your lunch hour for a lot of you on this Thursday. This is our second free webinar to help celebrate Occupational Therapy Month at Gowan. My name is Lauren. I'm the training manager at Gowan Consulting, and I'm also an occupational therapist. And for today, we have a great topic that we wanted to share lots of amazing information on. And I will hand things over to Kaylee Cunningham. She is also an occupational therapist at Gowan Consulting, and this is kind of her area of expertise. So I know I've used her as a resource before, and I'm happy that she's here to share lots of insights for everyone. I'll hand things over, Kaylee.
Okay, thanks, Lauren. Hi, everybody. My name's Kaylee. My preferred pronouns are she, her, and like Lauren said, I'm an OT with Gowan Consulting. Currently, I'm acting as the clinical lead for WSIB files, and trauma is an area that I'm passionate about. So hopefully, everybody can learn a little bit about what OTs do in this area today. So I'm pretty excited about it. If you have any questions, please go ahead and put them in the chat and I will try and get to them. At the end, we'll have a little Q&A. So first, just before we begin, I'd like to acknowledge that the land that I'm situated on is within the traditional and treaty territory of the Mississaugas, and more specifically, the Mississaugas of Scugog Island First Nation. And I'm really grateful to be able to work, live, and play in this beautiful area here. I'm next to Lake Ontario, and I just want to acknowledge that before we move on to the rest of this talk today. So just for the understanding of like what we're doing today, I didn't want to get too much into what trauma is because there's a lot of material about what OTs do. So I just want to have a little bit of an intro first on trauma. So I will talk a little bit about trauma, but mostly the effect of trauma on mental health and performance at work is one of the goals of today's talk. Learning the phases of trauma treatment, how reactivation and exposure therapy support post-trauma and during the return to work, and then some examples of accommodating trauma in the workplace. So just as a general overview, what is trauma? So one way to define it is just the 3 E's. So the event, the experience of those events, and the long-lasting adverse effects of the events. So you can define it as a series or an event that's experienced as physically or emotionally harmful and which has lasting adverse effects on functioning and mental, physical, social, emotional, or spiritual well-being. An experience is important to think about because it's the individual's perception of the event, and an event may be traumatic for one individual and not for another. So how someone assigns meaning, labels the event, and is disrupted physically and psychologically, how their functioning is affected, that's really what's important rather than specifically what happened. However, there is also, you can look at the definition of a traumatic event, which is being exposed to death, threatened death, actual or threatened serious injury, or actual or threatened sexual violence. That's another way of really thinking about what those events typically are. But there's a lot of variation in how people interpret those events. Some people do develop traumatic responses and some people do not. Okay? And the other thing to note is that it can be a single event or it can be a chronic pattern of events. So that can influence how symptoms develop and the complexity of the treatment, because you might have multiple meanings going on, multiple interpretations of events. And things can kind of come together and exacerbate functioning that's already happening. So trauma at work then can be a single traumatic event, or it can be a series of ongoing stressful events. So we spend a lot of time at work So it makes sense that some traumatic events would happen in the workplace. Some examples of traumatic events at work could be a workplace accident, being assaulted at work, involved in a robbery or other situations like that at work, witnessing an accident, witnessing assault or a suicide. Some ongoing stressful events that can be traumas are repeated witnessing of traumatic events. So that's something first responders experience. Ongoing assaults by coworkers or superiors or by the public or customers. That could include like ongoing sexual harassment, sexual assault by coworkers or in the workplace as well. And so the effect of trauma on work, I want to be clear that I'm not really focusing too much on symptoms exactly, but function. So trauma can manifest in various ways. I think a lot of people think about PTSD, and that is something that we do see happening. But some people develop depressive or anxiety disorders, substance use disorders because of trauma. It's not just PTSD. So the main difference might be just the re-experiencing in PTSD. So that would be like the flashbacks that people might hear about that you're going to get with PTSD, and you might not get that so much with, say, a depressive disorder. But the effective functioning may be very similar to different disorders. And the diagnosis is not often that clear-cut anyways. And as OTs, we're often focusing on function anyways. So I'm just wondering if anybody has any ideas, maybe you can put in the chat of what you think the effect of trauma on work would be. So on performance, ability to form relationships, like what are people thinking? I'm just going to see if I can actually see the chat here. Yeah, so people are talking about concentrating. So that's a huge one. Concentration and focus, communication. Yes. Yeah, performance and focus. So yeah, the first thing I was going to talk about is cognition. So PTSD and depression, anxiety disorders, all affect cognition. So memory, attention, concentration, decision making. You can experience difficulty focusing on tasks, retaining information, or making sound judgments, which, as you might imagine, can result in decreased productivity and errors in work. It can also be really frustrating for people. And one of the reasons that we think this happens is related to just avoidance. If you're having lots of really uncomfortable, distressing thoughts and feelings, you're going to do a lot to kind of avoid that. And that takes up a lot of mental space. So there's a lot. So that's one way of thinking about it. There might just be less, mental room for focusing on the task here. The other thing is emotional regulation. Intense emotional reactions, so anxiety, fear, irritability, anger. If an employee is really struggling to manage and regulate their emotions, they could have mood swings, emotional outbursts, like just general difficulty coping with stressors in the workplace, which can then affect work relationships, overall team dynamic, and affect how you even are able to do your work. Because if you're in a really emotional state, it's really difficult, again, the cognition piece, to come back and do that work and focus. Re-experiencing the trauma, so that's something really common to PTSD. And just like emotional regulation, like it's very distracting. Being in a really highly aroused state can be distracting. So that emotional regulation piece, and then having actual reminders of the trauma, like memories, feeling like you're back there. I think we can all imagine that would take you really out of being able to focus on work and being productive. And I think one thing that isn't always considered is that after like a flashback can take hours for some people to come back to the present and really be able to re-engage. Clicker stopped working. Avoidance of people, places, and situations. So because of that, re-experiencing, people tend to avoid things. So that's going to limit growth. It's going to limit learning. You're not going to be able to relearn how to manage some of these things if you keep avoiding them. And it's going to keep people stuck in a lot of times in the workplace, because they're not going to be able to, move out of their comfort zone very easily and do work that might be, in the past might have been challenging, but in a really positive way. They might limit themselves. Sleep disturbances and fatigue. This is a big one because of the emotional dysregulation, flashback symptoms. Sleep is often affected, so trouble falling asleep, staying asleep, and because of that, people are obviously tired. So when we're tired at work, we're not our best. I think everyone's pretty aware of that. And for some people, like, nightmares can keep them up a lot. So some people are trying to function on very little sleep, and the sleep that they get is very low quality. And absenteeism and presenteeism. So time off work to manage symptoms occurs, and just time off work because people feel like they just can't function, and so they just don't come in, can be off for prolonged periods of time or very frequently, might be frequently late. And if they are at work, coming back to those cognition pieces and emotional regulation pieces, people might be there, but not really functioning well, not really there, not really doing the work. Okay. And so thinking about all of that, like, that's at work. So what about at home? Like, any ideas what home life would look like if that's work life? No? Well, I think we kind of all have an idea of, strained relationships. So I just mentioned briefly in the previous slide about relationships, but the emotional dysregulation can result in problems with forming relationships, maintaining relationships. So like with work, it would have been like collaborating on projects, participating in team activities. So at home, that kind of relationship stuff is going to be about the family instead, and friends. Saying poor coping skills, really out difficult ADLs, might be able to hide things differently, more easily depending on who you're with. I think that can be true sometimes in our family lives. Like, people might have family members who enable things such as avoidance behaviors, which sounds really nice, but then it might not actually help people move forward. So for home, we obviously have the self-care piece. So that's a big one for people. We talked about sleep already. Sleep routines can get really disrupted. Sometimes people are sleeping in quite late or awake really late. Sometimes people become afraid of the dark. So they have a reverse day-night schedule, which can also just occur because they just repeatedly are trying to catch up on sleep. So they sleep in later and later. Managing your health and exercise becomes really difficult if you're really fatigued. Eating, dressing, showering, just brushing your teeth, all that daily stuff becomes really challenging for people. Lack of motivation is a very real thing due to depression, which is very common with trauma. Childcare is really difficult. Thankfully, it's one of the things that people still tend to manage to do to the best of their ability. most of the clients I see prioritize childcare over themselves, and it is one of the things that keeps some people well, but it is a real struggle for people, and it can result in a lot of shame and other symptoms too, as people struggle to be a parent and feel like they're not parenting well. Home care. So all that cooking, cleaning, being able to grocery shop, do your errands, manage your finances, do the household planning and emotional labor. So that a lot of that is the emotional regulation piece, the cognitive piece. As you can imagine, if you can't, remember things very well, if you're distracted, your attention's not great, you're going to be having trouble managing your finances and doing your paperwork and paying the bills, remembering appointments, remembering whose birthday it is next week, keeping track of all those things. Grocery shopping is a big one because people tend to have trouble in a crowd. So they don't want to be out with other people. Same with errands and appointments. They don't want to be out with other people, often not in public. And this is a generalization. It's not everybody, but commonly occurring. Other things, leisure. So people stop enjoying things a lot of the time. It becomes really difficult to enjoy things the way you used to. So if people feel like this isn't fun anymore, why do it? So they stop. Getting around. So driving is another thing that tends to result in a lot of anxiety for a lot of people. Again, not everybody, but some people have trouble with driving, even if, the trauma had nothing to do with driving. And part of that is sometimes due to the cognition piece. People feel like they don't have the attentional capacity to drive safely. Another piece is the emotional regulation piece. So with PTSD, for example, there can be road rage is pretty common, and people don't like, being that ragey, angry driver. It doesn't feel good and they don't feel safe. And at the same time, kind of a flip side of that are the people who take risky behaviors, and sometimes that's related to driving. And that risk is just sort of like I don't care about myself anymore. I just want to feel something. Relationships, socialization, and community. So we talked a little bit about this already, but intimate relationships really suffer a lot of the times with trauma. Due to the vulnerability of it, a lot of times people really have trust issues from a trauma, and then to be vulnerable with somebody becomes really difficult. The emotional regulation and anger piece also makes it really difficult to have those intimate relationships if you're always angry and then your partner can't understand why you're angry. And, you could have the most patient partner as well, and it can be very trying for both people in the relationship. And then outside of the home, so seeing friends, being able to volunteer, just participate in the community generally becomes really difficult because of that social piece, because of, managing your symptoms in public. People are often feeling embarrassed because they are like, what if I have a flashback? What if and I'm out in public, what will people think of me? And then the stress of being in a crowd is very triggering for some people. So you just have a whole bunch of things coming together to make, actually participating in life outside the home really challenging. So the stages of trauma recovery, people don't necessarily move from one stage to the second stage to the third. But generally speaking, there's 3 stages that people move through. The first one is just safety. The second, processing and remembering the trauma. The third is reconnecting. So the first one, we're working mostly on stabilizing symptoms, working on reintroducing self-care, giving grounding strategies, just things for people to start to feel safe again in their bodies and in their homes and close environments. The second stage is where we do most of the exposure and behavioral activation work. So that's the processing of the trauma and transforming things, creating a new story. And then the third stage continues the, I think, behavioral activation piece, which I'll be getting into a little bit more. And that's reconnection. So with yourself, with others, like redefining yourself in the context of those meaningful relationships. So getting back to socialization, getting back to things that are important to you. And then from the tasks of recovery to tasks of ordinary life. So moving from working on getting better to just letting things be ordinary again, which is a big shift for people and sometimes feels very anticlimactic, like the drama's gone almost, is what one client said to me. But it still feels like it's meaningful. It's ordinary, but meaningful. Oops, sorry. And related to that, there is an occupational therapy trauma intervention framework, which was developed by Megan Edgelow and Heidi Cram, which are their OTs at Queen's. They're professors there, and they study a lot of the effects of trauma in first responders and how OT is helpful there. So they developed this framework, which corresponds really nicely to the phases of trauma treatment. And so the first stage of OT treatment is really just this facilitation stage. So again, building rapport and trust, creating safety, and then you're doing stuff like self-regulation skills. So exploring the basics of breathing skills, relaxation skills, practicing things in safe spaces. Really, that safety piece is really huge there. And you're setting the stage for later therapy. Okay. Stage 2 is where the reactivation and exposure therapy are happening. So you're grading activity participation, you're doing emotional processing through exposure therapy, usually doing behavioral activation before exposure. Excuse me. So people have a bit of a safe routine, although goal setting is still occurring throughout exposure. You're getting more occupations that help to self-regulate instead of just, breathing skills or relaxation skills. You're developing, getting people back into their exercise routines or yoga routines or like stuff that's fun, leisure, things that can help regulate, that's not just a skill, that's actually an occupation. And then the engagement piece. So that's the resilience piece, that's the growing piece, which not everybody has, and you don't have to, but we see it often enough. And it's really, really cool to see that people can make new meaning, move into something new. And this is often where you get the return to work and productivity piece. And that's where you want to have that well-developed repertoire of self-regulation strategies that are used regularly. You have a routine, you have social connections, and really just engaging in things that are meaningful and valuable to you. And I just wanted to make a note here on timelines, because I think that's a question we sometimes get, like, how long is treatment? And I think it's important to note that the frequency and the length of treatment is dependent on the level of functioning at assessment and throughout treatment. So we know that it's not related, like the level of functioning is not necessarily related to symptom severity. So symptoms can be really high, but with a high level of functioning and vice versa. So it's hard to kind of say how long everything takes. However, that first piece, the safety piece, you can imagine for some people takes a really long time to feel safe, but then they could speed through the activation and engagement pieces. Although I kind of think of the engagement piece as like a lifelong piece. And then for some other people, They might feel safe right away, like pretty quickly, because they're out of the trauma. They recognize that, but then they're doing a lot of processing work, or they're really depressed and they have a lot of activation to do. Like if they've really had a really lot of a decrease in functioning, that can take a really long time. So the role of OT in reactivation and exposure. So just a little bit more about behavioral activation and exposure. So one definition of behavioral activation that I really like is just getting clients more active and involved in life by scheduling activities that have the potential to improve their mood. Okay. And for exposure, organize contact with repertoire narrowing stimuli for the purpose of increasing response flexibility. That sounds really confusing. I will go into that a little bit more. So most OTs use different psychotherapy approaches, but approaches all tend to have this behavioral activation and exposure component built in. Most psychotherapy, we're getting people reactivated and we're exposing them to uncomfortable thoughts, uncomfortable feelings, uncomfortable activities, things they're avoiding. The focus for reactivation is on valued or meaningful activities that provide a sense of agency. So in addition to pleasurable activities, we want to do things that are valuable to them, but maybe not so fun. So a lot of people with depression, so whether that's from trauma or not, state that there aren't really any activities anymore that give them a sense of pleasure. And so then they're frustrated if you're just giving them things that are supposed to be fun again, and they're not. So part of the focus is on valued activity. So things that give them that sense of mastery again. Like not everybody, I don't like brushing my teeth, but I do it, right? And I feel good about having done it. And I'm sure a lot of people are the same, right? So doing things that are valuable is a big part of that, in addition to just doing things that are leisure activities that give back to you in different ways. And then exposure exercises. Those are often driven by a certain topic and by the severity of anxiety, whether it's low or high. And it's a little bit more specific than the behavioral activation. So it's driven by what's standing in the way of being the person that you want to be and living the life that you want to live. So you're not going to do exposure for no reason. It has to be for something that's actually valuable to the client. And there's different types. So you can do the in vivo is the one I think most people are most familiar with. When you think of OT, you think of OTs going out in the community with people, exposing them to parts of the workplace, things like situations where a trauma might have occurred. But then you can also have imaginal exposures. If it was a memory, if part of the exposure cannot be recreated practically, we can do an imaginal exposure to that. List out the story or imagine the situation. There can be interoceptive exposure. It's really common. So that's to those internal thoughts and feelings. So you can either trigger them on purpose, or sometimes they're just there in the moment anyways, and you're kind of helping people refocus their attention on them. So exposure in a clearer way is just approaching difficult thoughts, feelings, memories, sensations, situations in order to act like the person that you want to be and live the life that you want to live, which is not to say that it's easy. So I took this from a Gowan and Homewood Health return to work services training I had a number of years ago, which was really helpful, but I wanted to see if I could find this picture somewhere else, but it's the only place, and it's one of the best diagrams, I think, when I think about engaging and disengaging, so both behavioral activation and exposure are working on engaging people after disengagement. So if you're having a bunch of experiences, so those events and those experiences, and you're getting those losses, setbacks, worries, you're being treated poorly, don't have enough positive events going on, that can lead to those symptoms, which can lead to behaviors. Whoops. I don't know what just happened here. Which can lead to, decreased sources of meaning and well-being and positive experiences. So then through reactivation and exposure, we're trying to reverse that cycle. So more opportunities for positive experiences, more opportunities for learning, and more opportunities to realign with valued actions. So reactivation covers sort of a wide variety of activities. So I'm just going to go over some in this slide and the next slide. I think first and foremost, we start with psychoeducation with our clients, sort of reassuring them, supporting them, providing a lot of validation for what they're going through, ensuring that they feel as normal as possible, like you did not go through a normal event, but your reaction is normal. Providing information on OT, what we do. A lot of people don't know what we do. So we're coming in to be like, this is what we do. This is how we're going to work with you and your other treatment provider. And providing information on whatever health condition they have, whatever mental health symptoms that they have, can be often really confusing for people. And a lot of people, sounds surprising, but it's not. A lot of people are be like, oh, I didn't know that was a symptom of my anxiety, for example, like the sleep disturbances. Sometimes people don't realize how closely that's linked to the trauma or their symptoms. A lot of people don't recognize their anxiety symptoms because they're so varied. You can have, the typical heart beating, but some people have swallowing issues. They don't realize that that's related, or they just feel really like buzzy and lightheaded, or have hand tremors, feel hot, cold flashes, or just, they don't recognize that their thoughts are maybe more just related to their anxiety, like thinking about death all the time or catastrophizing. They don't realize that that's a symptom. And then they also might not realize that the lack of motivation, lack of enjoyment is a symptom too. And it can be really helpful and validating for people to realize that those are symptoms, and that there's a way forward through them. The next piece is symptom management. So if you're thinking about that phase 1 of trauma treatment, those are the strategies. So grounding strategies, beginning those mindfulness skills and strategies, which we're going to take all the way through, and start to incorporate more and more into a regular routine, relaxation strategies, and that feeling safe piece. SMART goals. So OTs all love SMART goals. Goal setting is a huge part. And again, it's very dependent on modality, how the OT determines those goals, and gets the follow through on those goals. But I think for everyone, we're starting small and we're building bigger and bigger. And we're starting with things that people really value. We try and keep things really specific and time limited as possible, and work on those every session with people. And the other piece too is we want those goals to overlap with the return to work as much as possible. So what goals can you have that are helpful and valuable now that will also translate into a sustainable return to work? Routine building, so developing a regular routine for sleep, self-care, all that, preparing for like a work schedule. So we want that sleep to be, schedule to be on track for what your schedule is going to be when you return to work. We want you getting up at, an appropriate time. So getting things back to the way they used to be, maybe. And like I said, we want to grade goals. So increase frequency, duration, demand gradually, so we can get increased participation, increased endurance, increased engagement, and hopefully match overall demand required for a return to work. So, and hopefully coordinate with a return to work timeline. So you can start like a graded return to work, at the maybe tail end of doing some reactivation at home, so that you can have a gradual increase all the way into full return to work hours and duties. Cognitive retraining. So we want to grade cognitively challenging goals and occupations, so that we're gradually increasing the demand on concentration, memory, and problem solving and other cognitive skills. And then at the same time, if needed, providing compensatory strategies. We're also doing cognitive reframing throughout this piece. So with return to work, there's often maladaptive thought patterns around the work environment, people themselves. So that's helpful to address in a structured way. And reframing of thought patterns also often co-occurs with changes in behaviors. So it can be helpful to also reinforce those changes in a structured way. And then we're also reinforcing that, it's not always going to feel good. And normalizing that. The last one is communication skills. So a big piece is people are worried about going back to work. What are people going to say? How am I going to talk to people? Communication is often an issue before people go off work. So role playing, practicing, discussing what you would say can really help people feel confident about returning. Exposure. So again, psychoeducation. So how avoidance fueled anxiety doesn't make it better, makes it worse. We're developing an exposure hierarchy with people. So using values to make a plan to increase the ability to be in contact with the trauma triggers. And what's happening through exposure is learning, really. So you're increasing your skills at being present with your own thoughts and feelings. You're being able to determine whether, are those hurtful or harmful. So anxiety feels really uncomfortable, but it's not harming you. And so people really learn the difference. Cognitive restructuring is happening at the same time. You're learning, oh, I did that. I can do that again. And you're processing. So there's a lot of emotional processing that's going on when you go through exposure. And that can be really helpful for the emotional regulation piece. So just a quick example of what exposure might look like at the workplace. This is just a kind of made up case, not really. It's a couple of different clients combined into one. So a 38-year-old bus driver physically and verbally assaulted by a customer, referred for OT, is motivated for a return to work, but can't drive near his old route, or can't think about getting on a bus without feeling really dizzy and hot. He feels super on guard, and his chest will explode whenever he's near Eglinton Station. The assault occurred on Eglinton Avenue just prior to entering that station there. So this is an example of what that exposure hierarchy might look like. Sorry. So first, just listening to the sounds of the buses. And this is an example hierarchy, but these were real exposures. I just changed some of the details. And you might think that some of these, wearing the uniform, should be higher or lower, but it really depends on how people rate the exposures themselves. So again, that experience piece. But you can generally see that, it increases in proximity to the location of the trauma. and you're combining different stimuli. So at first, you can have the uniform alone, the sounds of buses alone, seeing a bus, and then you're actually in person at the bus stop, and then you're combining things like wearing the uniform and being on a bus, and wearing the uniform driving a bus, wearing the uniform driving a bus, and being at the station and where the trauma occurred. And so quickly now, I just wanted to go through some accommodations for trauma that you might, like that OTs might recommend. And this is to manage those cognitive difficulties, so attention and concentration, decreased stamina, like the fatigue piece, executive functioning challenges, time management issues, like with that, trouble with memory loss, trouble with just organization and planning, prioritizing, and difficulty with stress intolerance. So one thing is just modifying break schedules can be really helpful, making sure that people are really pacing themselves throughout the day. Same with task rotation. You might want to look at how people are doing the tasks, at what point through the day can can things be made more predictable, single tasking, can people be able to focus on one thing at a time, chunking time, not having to, being a little less like, not scattered, not having to do multiple things at once, but really being able to focus. Noise canceling devices can be really helpful, provided people feel safe in the workplace. Like some people actually find that stresses them out because they really want to be able to hear what's going on around them and be aware of the environment. So that, again, all these accommodations are, gone over with the employee. They're all individualized. Repositioning where they are working, so they may feel more safe sitting with their back to a wall or being in a certain part of the office. Flexible scheduling, if they have like emotion regulation challenges, it might be helpful if they can flex time, make up time, say they have flashbacks and they can come in later and finish their work later. Regular supervision, feedback is really helpful. Allowing assistance animals can be really helpful. Written instructions and requests for that memory piece. Modifying lighting, so anything that helps with cognition, so anything that makes things easier to see, easier to do, easier to organize themselves. The lighting piece is also really helpful for safety. People want to feel really safe at work. Allowing for phone calls to a support person, so that can help with that emotional regulation piece. And just knowing that they can call sometimes is enough. Disability awareness training for staff can really help, especially with the stigma piece. If people are worried about coming back to the workplace and they're worried about how it's going to look, knowing that people understand can be really helpful. Time management training, helping people with decision making and prioritizing and coming up with strategies for that. Allowing music on headsets. So again, that can help with calming. Organizational tools, so that's that cognitive piece, like allowing cognitive strategies and memory aids. Consistent shift scheduling, so really knowing what's coming is very helpful for people. Job restructuring, so can you get rid of certain tasks of the job that are not required? Can somebody else do that? And remote work. And then restrictions. So in addition to the accommodations above, there might be instances where someone can't return to work either to a certain location, or they might not be able to work in a location where a certain person is working anymore. They may have difficulty working with certain aspects of the job. So, for example, I had a client who was no longer able to operate a scissor lift anymore at work, but he could operate other types of heavy machinery. But because the scissor lift was involved in a workplace accident, that was a restriction, a permanent restriction. Other things like, carrying a gun might be a restriction for a police officer, and that might have to do with the emotional regulation piece where the client just doesn't feel safe anymore doing that. They might have to return to more a civilian role. Working night shift is a common restriction, working frontline emergency response as well, and then working with confrontation. So a lot of people find with the stress intolerance, they're no longer able to work in confrontational situations to the same degree they were before. Okay, I think I finished just on time. Just wondering if anybody has any questions for me. I'm just going to check the chat. Oh, someone was asking, does avoidance make things worse? Logically, long term, would it not be helpful to remove yourself from? Yes. So avoidance of safe situations makes things worse. So logically, you don't want, we're not putting, so with exposure, I should have clarified maybe, you don't want to be exposing people to unsafe situations. It's just safe situations, safe, that people are avoiding because it feels unsafe, but isn't. So we wouldn't be exposing people to things that are not safe. I hope that answers that question. Let's see. What type of impairment would support a medical restriction to not work for the workplace or employer? So I'm thinking more with first responders. They are often restricted permanently from working for the pre-injury, the employer that they were with. Often there's just too many triggers around that workplace. People often can't complete the exposures. They can complete exposures, but they may not be functional in those settings anymore due to how emotionally dysregulated they become in that place. So it just makes more sense if we can accommodate that and have them work somewhere else. I hope that answers the question somewhat. Let me know. Why would a first responder not be able to work for facility within the same court? So, I think it really depends on the individual. I'm trying to think of really specific, a long-term care facility. Okay, so you were, I'm trying to think of a first responder working within long-term care, which, yeah. Sorry, I lost the question here. Okay. I'm trying to think of an example of a first responder working in long-term care. I'm thinking more first responders like police officers, paramedics, firefighters. So, for example, police officers are usually the ones who don't return to the same employer. And often there's a lot of what we call sanctuary trauma around not being supported in the workplace that they came from, and they really associate everything to do with that workplace. with the trauma, and it just kind of all blends a little bit into one. And so they probably wouldn't be very regulated working at another division, say, because the culture really stays the same. And so they would have a lot of the same triggers. I hope that answers that question.
I can add to that as well, Kaylee, if it helps.
Thanks.
Yeah. So sometimes there are situations where they were working with a paramedic and they're unable to return to working on car or on ambulance. We may look at other positions within their larger organization, potentially a long-term care facility, if it is appropriate based off of how they've been presenting and their exposures. With our first responders, they're often in a lot of what we call safety sensitive position. And so if we do know that emotional regulation, stress tolerance is a challenge going forward, we may not want to put them in a long-term care facility where they have to respond to emergencies or safety sensitive situations themselves. But there isn't necessarily something, aside from what Kaylee said about the organizational stressors kind of being tied in with the trauma itself, that would necessarily preclude someone from working within a different unit within an organization. It very much is a case-by-case basis.
Yes. Thank you, Lauren. Christine, you said with reactivation length exposure process, what is WSIB's willingness to follow for the entire process in severe cases? I found they're pretty willing as long as clients are participating, engaged, and there is progress, even if it is slow progress in function. They are they're pretty helpful with, and they're pretty supportive of OTs continuing to work through the file to the end. Any other questions? Sorry, I know this was sort of a lot really quickly. Thanks everyone for coming.
If there aren't any other questions, Kaylee, do you have the next slide that?
Yes.
Yeah.
Oh, those are just my resources. Oh, yeah. Sorry, professors from Queens. That's Megan Edgelow or Megan Edgelow. She's right there. Here. But yeah, here. Here you go, Lauren.
So thank you again so much for joining us. We had an amazing turnout today. I hope you found this information really interesting and helpful for the work that you do. We do have some upcoming trainings or events within Gowan Consulting and our kind of training department specifically. So next week we are providing a virtual training for hybrid ergonomics. That's over the course of 2 days, and it's 3 hours per day. In December, we have a neurodiversity in the workplace workshop. And then upcoming in January 2024, we do have a cognitive demands analysis certificate training that will be offered in person, likely in the GTA area. And then for the remainder of OT month or occupational therapy month, we have 2 additional presentations. So next week we're having Kelly Stewart, one of our resident occupational therapists, give us a overview of neurodiversity in the workplace, ADHD, and kind of accommodations. And then the last week of October, I will be presenting on the OT role in ergonomics. So look forward to hopefully seeing some faces at those 2 events as well.